Hello, everyone, and welcome to another episode of the Determinants of Her Health podcast, where we examine the systems that affect women's health and how we can shape them. Today, we are talking about perimenopause. And I know this is a topic that has been, um, people have been really excited for, at least in my circles, and I'm really excited to learn more too. Today, I have with me Dr. Lillian Medhus of Aspire Women's Wellness. And Lily is actually a friend of mine. We lived together when she lived in California. So it's really nice to see her face again and to get to chat about this topic. So,
Yeah.
Lily, do you want to go ahead and introduce yourself?
Yeah, thanks for having me. I am a women's health nurse practitioner, and I've been practicing for about 9 years now. And over the course of the past maybe 5 years, my practice really took a turn towards focusing on complex and overlooked hormonal conditions in women. So I work with a lot of patients going through the perimenopause, the menopause transition, as well as looking at conditions like endometriosis and PCOS or PMOS now, as well as thyroid conditions and sexual dysfunction.
Yeah. I'm so glad that you are there as a resource because I know a lot of women can kind of get lost in the system or feel like they're not being heard or not even know like what questions to ask in that like quick 15-minute conversation that they may be having with their doctor. So it's great that you have your practice and you've also been a really great resource online as well, which is super cool.
Yeah, I think I try to use social media as well as teaching whenever I can in different capacities as a way to provide free education so that even women who may not be able to access care like I provide can still go into their own visits with some tools and ways to talk to their practitioner.
That's really, really cool. So what is perimenopause?
Yeah, perimenopause is some people call it like the zone of chaos. And it used to be thought of as a like a really distinct period of time. But I think now we're starting to understand it a little differently, where there's a lot of parallels to puberty. So I tell my patients like in the same way that you didn't go from being a child to being fully developed woman and having regular periods overnight. You don't go through you go from perimenopause to menopause overnight either. So probably when you went through puberty, like there were several years of development happening. Maybe you started a period, but it wasn't super regular, and it took several years for things to kind of like get online and start clicking. And perimenopause is the same thing in reverse, right? So in the beginning, you often start to notice some really subtle things. Maybe your mood is a little bit different, stronger PMS than you used to have, sleep disturbances. Then a little later on, maybe you have some changes in your periods. They start to space out or become heavier. And then a little further along, maybe you start to notice hot flashes, night sweats, brain fog. That whole transition is called perimenopause, and it can be 10 or 12 years for some women
Mm.
of that kind of almost phasing out of our reproductive years.
That's really interesting. When is it actually menopause? Like, what's kind of the marker where people can say, like, okay, I was in peri, but now this is actual menopause?
So menopause is one day. It's when it's been 1 year since your last period.
Okay.
And then the rest of your life, you are medically considered postmenopausal.
Okay. So it's interesting because I think at least growing up, we never heard about perimenopause. Like I know when I started becoming like aware of this, I had heard of menopause because of like women in my family going through it. And it seems like a lot of the symptoms you named kind of towards the end is what I kind of heard related towards menopause. And perimenopause just wasn't really a thing that people were like aware of. Would you say
Mhm.
that's kind of true?
Mhm. Yeah. Yeah. So a lot of the symptoms that people know of are more stereotypical low estrogen symptoms. And really, estrogen doesn't start to decline significantly until you're a lot closer to menopause. Really early perimenopause symptoms are low progesterone, and those are the ones that are often missed.
So is it that in perimenopause, when you kind of start getting into it, your progesterone starts declining and then later your estrogen starts declining as well. And then do both of them stay pretty low towards the end, or is there an increase of progesterone towards the end?
No. So yeah, progesterone declines first. And we get progesterone when we ovulate. So it comes from the what's called the corpus luteum. And so as you know, mid 30s, early 40s, you're not ovulating as frequently. Maybe your egg health is not as great as it used to be. You're not releasing as much progesterone as you used to. So progesterone in the uterus keeps the lining of the uterus thin, helps your periods be lighter, shorter, less painful. So that's why we see periods start to become heavier, longer,
Mm.
painful. In the brain, progesterone helps with sleep and anxiety. So that's why we often see an uptick in insomnia and anxiety in the late 30s, early 40s. Um, Whereas estrogen in the beginning, progesterone's like this, estrogen is like this. So you actually
Mm.
have days where you have really, really high estrogen coupled with low progesterone, and that's what can drive a lot of the symptoms. Later on is when we start to see the decline in estrogen that leads to hot flashes, night sweats, brain fog, body aches and pains, vaginal dryness,
Mhm.
that are maybe more known as perimenopause.
Okay. I know you already named a lot of the symptoms, but what are sort of the classic symptoms of perimenopause? And then what are symptoms that someone could possibly blame on perimenopause that maybe aren't, or maybe indicative of something else happening?
Yeah. So, I'll answer this a little bit differently, but we have over 50 hormones in our body. And
Whoa.
people come to me like all the time and say, I'm here because my hormones are messed up, right? Like that's what everybody says.
Yeah.
Which may be true. And they may have a hormonal condition going on. Most of them do. But what they usually mean is they think there's something wrong with their ovarian hormones. Oftentimes, we have to zoom back out and look at the whole picture and do a large lab panel because kind of at the top of the hierarchy of your hormones are insulin and thyroid hormones. If you're insulin resistant, you're running on high blood sugar, you have high insulin levels, or your thyroid is not optimized, that's going to downstream affect every other hormone in the body. So I see a lot of patients come to me for hormonal concerns, and in fact they do, but the hormone may be insulin or the hormone may be thyroid that drives a lot of the other things. So, as it pertains to perimenopause, we often see this overlap of insulin resistance becomes more common in
Mm.
perimenopause. Thyroid dysfunction becomes more common in perimenopause. So it can be difficult to kind of parse out what's coming from these other things and what's coming from the decline in ovarian hormones. Does that answer your
It
question?
does, yeah. Yeah, I think it's super helpful because I think a lot of times we know something's off, we're feeling these symptoms, we're not feeling the way we normally feel. And it's so easy as women to think like there's got to be something wrong with my ovarian hormones or what we would categorize as hormones. And I don't
Mhm.
even think I realized that insulin was a hormone. So that's really helpful to think about. Okay, there could be more going on here that is related to perimenopause, but maybe isn't those traditional hormones that we're
Mhm.
kind of thinking of.
Yeah, yeah. Yeah, so for perimenopause specific symptoms, some of the most common things that people tell me is I just don't feel like myself anymore.
Hmm.
And we actually have a study that came out last year that is a clinical symptom that's now recognized as women saying they don't feel like themselves.
Huh.
Oftentimes is an indicator of perimenopause. Difficulty sleeping, falling asleep, staying asleep, worsening PMS, or worsening anxiety that you didn't have before. So many people get put on mood stabilizers, SSRIs or SNRIs in perimenopause, which is not a bad thing, but if it doesn't treat the true cause of the depression or anxiety, which is hormone depletion, they may not actually get better.
Yeah.
Yeah, and then it's usually later when we start to see like lower libido as their testosterone declines as well. Hot flashes, night sweats, brain fog. Frozen shoulder is common. Mouth burning, ear itching, nosebleeds, worsening seasonal allergies. Basically, every organ in the body is eventually affected.
That's interesting. So I took a human anatomy class a couple semesters ago, which was so hard. And I was like, well, I know what area I'm not going into. I was like, this is not for me. But one of the things that they said, they were talking about the systems of the body, is was like day one, and just naming all of the systems. And the lecturer said, the endocrine system is, we are in our infancy in understanding the endocrine system.
Mhm.
And it's so fascinating to me because it seems like that's something that there's such a need for it to be studied when it
Mhm.
affects so many other systems, and
Mhm.
when it affects significant, like half of the population so
Mhm.
significantly.
Mhm. Yeah, yeah. Yeah, we definitely need more data. And one problem is that unfortunately, a lot of research is driven by cost, right? And there's no money to be made in hormone therapy.
Mhm.
Because we're using mostly, not always, but most of the time we're using natural progesterone and natural estrogen. It cannot be patented. There is no like financial gain to be made by doing more studies on these products, unless you were to make some form of, synthetic hormone replacement that hasn't been used before.
Mhm.
So there's not a lot of industry drive to do these kind of studies.
That makes sense.
Hmm.
Because there, maybe we'll dive into this. What is like a difference between a synthetic progesterone that would be found in like birth control and natural progesterone?
Hmm. Yeah, so most of the time, for my patients, they come to me wanting natural hormone therapy, right? That's why they seek me out. There are many reasons why you may use natural hormones over synthetics. One of which is that natural progesterone, when it breaks down into something called pregnenolone that affects the GABA receptors in the brain. So if you hear of people even taking like GABA supplements,
Yeah.
progesterone is kind of the upstream hormone that affects GABA. So natural progesterone is going to help with mood, sleep, and anxiety. Progestins, which are synthetic progesterone, will block those receptors, but not have the same effect on GABA. So they're not going to help with mood or sleep. Alternatively, synthetic progestins do have benefits for things like really, really heavy bleeding or
Mhm.
endometriosis or sometimes PMOS, PCOS, because they do work, they're stronger. So they're stronger at preventing bleeding, they're stronger at helping with pain than natural progesterone is.
That's super interesting. It makes sense why going on birth control, a lot of people find that their periods are much lighter.
Hmm.
I have tried to use birth control to treat PMDD
Hmm.
and been totally unsuccessful. And now that I learn more about what PMDD actually is and how it's not, it's really about those GABA receptors and how my brain is responding to hormones, it makes so much sense why birth control for me, and I know not this isn't true for all women, but it made the symptoms actually worse
Hmm.
than
Hmm.
making it better.
Yeah.
So
Yeah.
that's really interesting. What are the traditional treatments for perimenopause?
Um, so traditional is good luck. And maybe an SSRI if you're lucky enough to get somebody to listen to you. But the treatment that myself and my colleagues are trying to normalize and increase access to now is various forms of hormone therapy.
Mhm.
I will say that perimenopause is extremely challenging to treat. So it is not something that you can go in once and get your prescription and you're good to go. Because it's 10, 12 years of time. And in the beginning, like I was saying, progesterone's doing this, estrogen is doing this, and we aren't able to stop that. That's going to continue to happen. We're just trying to fill in the gaps. So instead of this, you're having this, right? You're still going to have some symptoms, even if you're on hormone therapy. You're still probably going to need a lot of dose adjustment over time as estrogen starts to shift and progesterone continues to decline. Um, so we use generally, natural hormone therapy, estrogen and progesterone, the same as what your body makes itself, unless you have other reasons why. Synthetics may be more beneficial. So, like I said, if you have endometriosis or PCOS or really heavy bleeding, or in some cases, people need contraception, right? So that would be another indication for
Mm.
using a synthetic versus natural. Natural progesterone doesn't prevent pregnancy. And then we're layering on hormone therapy to support mood and symptoms, and also help prevent disease. And we're looking at optimizing your insulin, your thyroid, nutrient deficiencies, vitamin D, B12, iron, ferritin. We're looking at your sleep hygiene, your diet, your exercise routine. Do you have support systems? Are you completely burnt out? Do you have
Mm.
boundaries enough to protect your mental health as your hormones continue to shift? All of those things are really important pieces too.
Are there conditions like endometriosis and PCOS, is it PMOS,
Mhm.
that can contribute to perimenopause symptoms being worse in an individual who has those conditions versus someone
Yeah.
who maybe doesn't?
Yep. So people with endometriosis tend to have a worsening endo due to perimenopause,
Okay.
because endo is primarily driven by estrogen, excuse me. So as their progesterone declines, they don't have the protection of progesterone anymore, and they have high levels of estrogen. It often worsens their endo. As opposed to people, for example, with PCOS or PMOS, they often have higher levels of testosterone. So they may not see as much of a decline in libido, for example, or
Mm.
maybe not as quickly as people that don't have that condition have. They typically have had low progesterone for many years because they often don't ovulate regularly. So they have not had progesterone often on board for a long time. So the management of PMOS actually intersects a lot with the way that we would manage perimenopause.
Mm.
ADHD, autism, and neurodivergence is often more challenging in people. Perimenopause is more challenging for people with neurodivergence as well.
Mm.
One, because progesterone impacts anxiety.
Mm.
Also, because estrogen breaks down into serotonin. So, if your estrogen is declining, now you have a decline in serotonin and dopamine, which are kind of the protective barriers for people with neurodivergence. They can see a significant worsening in their like executive functioning as they go through perimenopause as well.
I also saw, and this was just on Instagram, that there are some studies that find people with ADHD and probably other forms of neurodivergency are experiencing perimenopause earlier. Is that something
Yeah.
you've seen as well?
Yeah. Yeah, and I don't know if if it's earlier ovarian decline, or if it's because they have less protection that they see the symptoms neurologically sooner. But either way, we do tend to see those patients earlier on with concerns, and they do tend to be more significant.
That makes sense. What age range is typical for perimenopause?
Um, as early as 35,
Oh, wow.
and most people will be at least early perimenopause by the time they're 40.
Okay. Man, it's right around the corner for me. It's so interesting because I actually need to think about this. I've noticed that my ADHD symptoms have been much worse, and I've just kind of been blaming it on being so close to getting my bachelor's and being burnt out. But I wonder if there is
Yeah,
more going on. Like, it's
yeah,
really interesting.
yeah.
Yeah.
Yeah, and I think that's like the thing with perimenopause too is like it hits around the time when many women have young kids at home and a
Yeah.
career that they're trying to balance. And so historically, that's been the excuse, right? You're burnt out, you're stressed, you need to sleep more
Mm.
without acknowledging that there's also something physiologic happening.
Yeah. And then telling women they need to sleep more when they're already struggling to
Mhm.
sleep, or they have
Yeah.
young kids who also don't sleep.
Yeah.
That's tough. You mentioned a couple natural supplements, but what are some things that can be helpful? I know I was advised to take magnesium, and I've noticed a difference in my own sleep with magnesium. But what are some things that could potentially be helpful that someone can go and buy at
Yeah.
like a CVS?
So I do tend to be a bit of a supplement, simplest. I don't know the right word for
I
that,
like
but,
that. Yeah.
so I often encourage people not to supplement much until they've tested and see if they actually need the supplements that they're taking.
Mm,
I always give a word of caution that there are a lot of perimenopause supplements on available at CVS, Walgreens, with a lot of like labeling around perimenopause.
mm,
And if you look at the ingredients, they're often just a marked up like multivitamin. So I would be really cautious around that. Some people will take like blue cohosh or black cohosh. I again, like we just don't have a lot of data that that's supportive and actually can be harmful to some patients.
mm.
So I keep it pretty simple, like a high quality multivitamin, replacing vitamin D, B12, and iron if your levels aren't optimal. And so seeing a practitioner who maybe is more aligned with like integrative medicine or functional medicine, where they're going to look at optimal ranges, not just like the large lab window.
Yeah.
Um, Fish oil can be supportive for many people as far as like sex hormone production, right?
Mm.
We need healthy fats in order to produce our sex hormones. So that's the building blocks to them. So both in your diet, getting omega 3s, and also you can take a fish oil. Magnesium glycinate is helpful for many people for sleep. It also can help with muscle cramping and relaxation. So that's a helpful one that I use in some of my patients. But I do tend to kind of go along the lines of treating levels that need to be treated once we've tested.
Yeah. So it's better to test first and make sure you're not, just buying a vitamin that you're not necessarily needing, which I
Yeah.
think, yeah, completely makes sense. I think a lot of times yeah, that the targeted marketing is frustrating if you're just looking for some kind of relief
Hmm.
and you're seeing stuff at the store that's like, okay, this is going to grant me relief. And then maybe it's not the thing that you need, or maybe it's marked up, like you said, and it's not something that, you can just buy a women's daily and
Yeah.
call it a day.
Yeah.
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 I did see recently that the levels of certain things were changed for women, right? Was it iron? And was there another one that they recently said that like we had been saying women who were kind of low in those areas, or maybe were testing still within like the median, but on the lower side, those women were actually low on those vitamins because
Yeah.
the range was put on general men and women,
Yeah.
whereas women are actually more at risk of having lower iron, or their levels need to be at a higher rate. Is that correct? Am I saying that right?
Yeah, yeah. Especially ferritin. So ferritin
Ferritin.
is like what carries iron where it needs to go.
Oh.
Many times people are not even checking ferritin, and if they were, the lab range is, I want to say it's like 15 to 100 for most labs. But most women really need to be at least 60 to 70.
Mm.
Same with like vitamin D. Many labs will say 25 to 100 or something like that is normal, whereas most women will function their best with it if their vitamin D is at least 60 to 70. So there's many nuances there too. Same with thyroid function and insulin as well. If you just go on the lab range, it doesn't necessarily mean that that's going to be optimal for you. same thing when it comes to testing estrogen, progesterone, and testosterone. Oftentimes, if practitioners are not skilled in interpreting those results, all they will tell women is, "Hey, your labs are normal, and there's nothing we can do for you." But it really takes a skilled provider to know how to interpret those results in the context of the patient's history.
Yeah, that makes sense. So we've kind of talked a little bit about this, but like zooming out to the systems level, where do you think some of the gaps are, whether that's in research or education or maybe even legislation? Like what are some systems level things that are maybe contributing to people sort of falling through the gaps?
Mhm. I think one of the biggest ones is education in nurse practitioner, PA, or MD programs on midlife health. Even, really great to get education on how to do hormone therapy, but even a bigger look at like what does menopause mean for heart disease risk? What does it mean for Alzheimer's, for type 2
Mm,
diabetes, for osteoporosis? And having more education on midlife health promotion and prevention, as well as how to use hormone therapy, I think is a huge gap.
yeah. And then what about on the research side? Is there more research that's being done into perimenopause, or is it one of those things where, like you said, there's not really the industry driver, so it's not
Mhm.
really happening?
Yeah. Um, no, there is research being done. I mean, I think we probably are all aware that a lot of research funding has been pulled in the past few years, which makes a huge impact, especially when many of the studies that were being funded were for women's conditions. But there are a lot of grassroots researchers, which is really encouraging. There's an organization that I'm a part of called ISWISH. That they do a lot of more like grassroots research, utilizing medical students and residents and fellows to conduct some of those studies. So I do think that there's research being done, and we can be encouraged by that. But yeah, there may not be as much industry funded research because the products, like I said, they're not patented.
Yeah.
Um, for example, I think we're all really hoping to get a female FDA approved product for testosterone replacement. We don't have that in
Mm.
the United States. So we have to use male products or use compounded products in other countries. They have female dosed testosterone. But again, unless you are adding something to it or making it something different, testosterone is testosterone, right? There's
Yeah.
nothing new to market it.
That's really interesting. Yeah, I had no idea that there was no, yeah, that there was no female version of that.
Yeah,
That's
yeah.
interesting.
Yeah, so some of the studies that you'll see coming out will be on some more unique products that also have a place in menopause care. So one example would be something called Duavie. It's a really unique product. It's estrogen and something called basidoxifene. It does not have progesterone in it, so it's used for people that can't take progesterone or don't tolerate it.
Mm-hmm.
So we have some really great studies that came out on using Duavie in people who are at risk for breast cancer, for example. So we do see more research being done on those kind of patented products.
That's really cool. Yeah. And then I guess from the legislation lens, having something that's FDA approved
Hmm.
would be kind of that route of like the systems level. But
Hmm.
yeah, it makes sense that like education would be sort of the top priority, helping people be more educated about this because for us as women, the first place we're going to go is to our primary care physician
Hmm.
to say, like, hey, I'm not feeling myself. And so for them to have, all of this evidence, I'm really fortunate that I really like my primary care doctor. And when I've talked to her about other things, she said, I'm currently educating myself a ton about perimenopause and about hormonal issues in women. So she's like, you'll be in luck once your time comes because in a couple of years I'll know a lot about it. And I was like, thank goodness. It's like
Yeah,
it was really
yeah,
refreshing.
yeah.
But to that point, like that's something that she has to kind of do on her own time to educate herself. It's not something that she was given during her normal, I guess, medical
Yeah.
education.
Yeah. Yeah.
Yeah.
Yeah, so we're lucky. I mean, now that there are a lot of continuing education programs available for menopause care and hormone therapy, but providers have to seek it out themselves, pay for
Mhm.
it, and take the time to do it. And they may or may not be compensated for that by their,
Mm.
the place that they practice.
Yeah. And I wonder what that's like in like the bigger institutions, like when
Hmm.
you have like a Sutter or a Kaiser versus like someone who's in private practice. Like,
Hmm.
yeah.
Yeah.
Um, which there's like a whole conversation to be had about private practices being in decline,
Hmm.
just from the overhead that they have to take on.
Hmm. Hmm.
Um, what are some of the things that you wish people knew about perimenopause just for like the just general everyday person?
Hmm. Yeah, I wish that for women to know that it starts in their 30s, right? So they don't need to suffer for 10 years before they come in to get help. Many people come to me and it is maybe sometimes hard to hear that they're in perimenopause because they think of that not being for young people, right? They feel
Yeah.
young in their body, but they feel like they shouldn't be going through perimenopause. So just know that it's very, very common for it to start in your mid to late 30s. And I think that we have really, really effective, um, low cost, sometimes free, natural hormone therapy options that work for most people. So this is not something that, cost should be a barrier in most cases, to you
Mm,
being able to feel well, and also know that hormone therapy reduces your risk for disease later in life.
that's crazy. Where would someone go when they're okay? So like I said, the primary care doctor. So someone's experiencing these symptoms. Maybe they go to their primary care doctor, and their primary care doctor says, like, "Good luck," like, welcome to being a woman, or they're not very supportive. What would be their next step in sort of advocating for themselves if they're staying within that medical institution, or where somewhere else that they could go?
Yeah. Yeah, it's tricky because some people don't have access to other places to go, right? They can't just like quit that provider and go somewhere else.
Yeah.
On the flip side, if your provider is not very confident in treating perimenopause, you may want to think if that's really the person you want to treat your perimenopause, right? Like,
Yeah.
we also don't want to kind of push people into treating something that they don't have experience with, because
Mhm.
that's where sometimes some of the negative side effects come when hormones aren't managed well. So there are, and I can share this in the notes or whatever,
Mhm.
like a screening tool for perimenopause that you can use to see like what symptoms you are experiencing and how much that's affecting your daily life. Having some numbers, some hard data can be helpful to
Mhm.
show providers. I think having a couple of like things that on the top of your mind that you're going to say like, hey, this is affecting my work, or this is affecting my ability to do my daily tasks. Sometimes that will kind of trigger people to look into it more. Also, not trying to address this at your annual. Please don't try to
Mm,
address this at your annual. Many women think that's my time when I'm going to address all my problems. That is not how practitioners, especially in large systems, think about an annual. That's a preventative visit. You're going to get your screenings, your labs, your PAP, whatever you order for your mammogram. They often do not have time to address problems in your annual. So make a separate visit to address and put in your, when you schedule that you want to talk about perimenopause. I think that goes a long way too. Know that you may have to have multiple visits, especially if you're going somewhere where you have only 10-minute visits. You may have to come back multiple times to get your needs taken care of. And if that's not working, then that's when I would consider going somewhere else, right?
Yeah.
You can look on the Menopause Society, has a list of all menopause specialists throughout the United States. I would look there for someone in your area that's menopause certified. That means at least they are interested enough to pay the money and go take a test to be listed in this listserv. They may not be the perfect provider for you, but at least they, have gone that extra step. ISWISH has a list of practitioners as well that may be able to help you. And then, honestly, many of us in private practice are on social media.
Mhm.
So look to see on social media, on their website, do they even talk about perimenopause? If not, it might not be the place for you.
Yeah. That is so helpful. And it's so funny you say that because I totally like make lists for my annual of here's all the problems I'm having. And yeah, there really is no time to
Mhm.
to talk about all those things. And it's
Mhm.
interesting to think about that from the provider's mindset of like, okay, we are doing all of the tests, all of the checks, all of everything for the preventative care. And yeah, having a separate appointment just to talk about that specifically, I think is really good advice. I think a
Mhm.
lot of times for us, like at least I have this mindset of like, I will put it off until my appointment.
Mhm.
And so maybe just to shift the mindset to, no, if it's bothering you, if it's really interrupting your life, just make a separate appointment now. Like it's not worth putting it in your notes app and waiting until that appointment
Mhm.
day, but just sending the email off and kind of getting the ball rolling as soon as you're
Yeah.
starting to feel the symptoms is probably worth it.
Yeah. Yeah.
Especially if you're like me and you're in a big hospital system where it's going to take 6 months for an appointment
Yeah.
anyway. So
Yeah. Exactly.
yeah,
Yeah. Yeah.
yeah.
Yeah. And if you're sitting in your annual already and you're like, hey, I have these things to talk about, you can say that, I have all
Yeah.
these other concerns. Would it make more sense for me to come back for a follow-up visit? How soon can
Mhm.
you get me back in?
Yeah. I probably should have asked this earlier, but is there a test that can confirm whether or not someone's in perimenopause, or is it more of a self-assessment?
We call it clinical diagnosis. So that's why, one, we do a big lab panel, right? At least in my practice, we do, is we want to rule out everything else that could cause those symptoms. So
Mm,
thyroid conditions can cause irregular periods. Insulin resistance can cause hot flashes and mood swings. Nutrient deficiencies can cause fatigue and brain fog. So, part of the lab panel is to make sure there's no other reason to explain all of the symptoms that you have going on.
yeah.
And then as far as like a test for perimenopause, it's a little controversial. If you ask some menopause specialists, they will say they don't test sex hormones at all.
Mm,
If you ask me and a lot of clinicians that I work with, we do often test sex hormones, but in context, right? So we're going to have you time it usually at a certain point in your menstrual cycle. So we have
mm,
something to compare to, knowing that your hormones are changing every day. And then we're going to interpret it in the context of your symptoms, right? So if you have symptoms of low estrogen and your estrogen is really low, that kind of puts the picture together for us. But even if your labs are quote unquote normal, and you have all of the symptoms of perimenopause, your age makes sense. We've ruled out other causes of these symptoms. We're still going to treat you, and we can still do a trial of hormone therapy. And if it works, then great. We figured out what it was.
mhm. So do you think it's worth people asking their providers to run some of these tests, or is it better to kind of go the symptoms approach of like, let me paint a picture of all the symptoms I'm experiencing and kind of try to put the puzzle together from there?
I think it depends on how competent your provider is in treating menopause. um, because just getting a lab panel, if it's not interpreted correctly, actually can sometimes do harm. I see many
Mm,
of those patients where they got the lab panel that they advocated so hard to get from their provider, and then they fell in the normal range and they were told
yeah,
there was nothing they could do for them and they weren't in perimenopause. So I think having both, like going through the screening yourself, understanding what perimenopause is, and labs can be useful in some instances.
that makes sense. Yeah, I could totally see that of just being kind of put on the normal range, and the doctor has, you know, kind of they have the peace of mind of, okay, you're
Exactly.
within normal, we're good. We don't need to
Yeah.
take any interventions here. Um, but yeah, but then you're still suffering from these symptoms like, well,
Yeah.
I don't
Yeah.
feel normal.
Hmm.
I just love that the idea of being able to tell a provider, I don't feel like myself is now an actual symptom. Like that
Hmm.
is so huge, I think, for so many women, because we all know what that feels like
Yeah.
to have that I don't feel the way I normally feel.
Hmm. Yeah.
Yeah.
Yeah. Yeah. It's very common, especially I would say in late 30s, is to just kind of start to feel off, but not have words to put to it necessarily.
Yeah. Okay. Any other tips or anything on your mind about how people can advocate for themselves, resources they should be looking at? And again, we'll put all these resources like in the show notes, but what's something that you think people like are at the top of like need to know?
Yeah, there's a lot of voices online right now, so I would carefully vet the people that you listen to. You should be
Mm,
able to easily tell their credentials by looking at their bio. So know who you're listening to before you follow their recommendations. And then read books. I think that's a great place to start. There's an excellent book called Estrogen Matters, all about
mm.
why we need estrogen to prevent disease. There's a book called The New Perimenopause that's really helpful for a lot of my patients. And that's kind of a good place to start as you explore what might be going on and how you want to approach this time in your life.
Yeah, that's super helpful. Interesting that estrogen also prevents disease.
Mm-hmm. Yeah.
That's fascinating.
Yep.
Probably a hormone that's been kind of overlooked, but
Mhm.
yeah, to know that is really cool.
Yeah, yeah. We know it prevents osteoporosis, which is one of the, things that women end up in the nursing home for
Yeah.
often. And it likely prevents also or reduces the risk of heart disease and Alzheimer's and other metabolic disease too.
Wow. That is fascinating. Lillian, thank you so much for joining me and for answering all these questions and providing so much information. Where can people find you? And can you tell us a little bit more about Aspire Women's Wellness too?
Yeah. So I'm on Instagram at Aspire Women's Wellness. Our website is just aspirewomenswellness.com. We are a small boutique practice focused on chronic overlooked conditions in women, specifically perimenopause and menopause, sexual dysfunction, chronic pelvic pain, and related conditions. So we spend an hour and a half with every patient. We go through really in-depth lab work and try to build a partnership with our patients long term to help them thrive in midlife and beyond.
That's amazing. And if
Yeah.
someone's listening and they want to be a patient, if, what are some of the areas where you're licensed in?
Yeah, we're currently able to see patients in Texas, Oklahoma, Missouri, Minnesota, and Kansas. But if you live somewhere else, feel free to reach out to us. We are always looking to expand to other regions. I also have a huge network of trusted clinicians that I can hook you up with too if you're in a state that I don't serve.
That's really helpful. Thank you so much.
Yeah.
Awesome. Well, thank you everyone so much for listening. As always, please like and subscribe and share this with a friend. To learn more, you can visit our Instagram at determinants.pod and you can email me at determinantspod@gmail.com. I hope you all have a beautiful and healthy day.